Welcome back to LIMBWatch, where we bring together the world's leading experts with one mission: preventing amputations before it happens. Today, we're honored to welcome one of the true pioneers and national voices in limb preservation. Today, joining us is Dr. David B. Alper. Dr. Alper is a podiatric physician, recently retired from practicing in private solo office. He started 39 years ago in Belmont, Massachusetts. Specializing in surgical treatment and preventative diabetic foot care, he is now emeritus of surgical staff at Mount Auburn Hospital, Harvard Teaching Hospital. He is currently a member of the leadership board of American Diabetes Association in New England, having served as president for over 20 years, and is an elected member of the board of trustees of the American Podiatric Medical Association. Since his retirement, Dr. Alper spends much of his time in the world of limb amputation prevention as a result of PAD, CLI, and diabetes. He currently serves as the board member of the Wound Care Collaborative Community, the Alliance of Wound Care Stakeholders, the PAD Collaborative of the American Heart Association, the CLI Global Communication Committee, the Global PAD Association, and is a founding member of the Medical Advisory Board of the Amputation Prevention Alliance of the ADA. Dr. Alper is also an adjunct professor at Northeastern University PA program for over 3 decades, and he continues to participate in and create webinars, videos, lectures for both medical professionals and community, focusing on educating regarding PAD, diabetes, and amputation prevention. He is also a noted speaker, writer on a variety of podiatric topics from both medical professionals and for the general public, including articles published in Prevention Magazine, Health Journal Magazine, and Walking Magazine. And he is also a familiar figure on Capitol Hill in DC, giving congressional testimonies and visiting legislators on issues related to medical care for those with diabetes and PAD, all to prevent amputation and make patients' lives better and ensure that they're heard. When not in the world of feet, you can find him in his blacksmith Ford or with his wife Pam and three wonderful children, Megan, Adam, and Brian, and his equally wonderful Shih Tzu, Gizmo. So, welcome, Dr. Alper.
Well, thank you so very much for that wonderful introduction. I'm thrilled to be here.
Awesome. So, Dr. Alper, can you walk us through how you first got involved in limb salvage and what led you to focus on policy and legislative side of it as well?
Well, if you're in the world of podiatry, you're going to be faced with people that are at risk of losing their limbs. They come into you with wounds, they come into you with circulation issues. Hopefully you catch them early enough. But the reality is that over the course of my time, I found myself amputating just more than I wanted to. People would come in with toes that were lost to the ends of their feet. And it struck me that it was time to try to help them, because medicine nowadays even today, is focused so much on reaction rather than preventative or proaction. And so rather than simply saying, okay, it's time to amputate, we have gangrene, we have no circulation, I wanted to start focusing more on what we could do to prevent this type of thing, to really get the insurance companies and the government to be proactive in medical care. And the only way to really do that is to advocate, to get the information out there, to get the knowledge out there, and to speak to these people and put it in front of their faces and say, this is just wrong. And so I started speaking to other people in this world, vascular surgeons, interventionalists, PCPs, and of course other podiatrists. And nobody disagreed with me. I mean, how do you disagree with somebody that wants to prevent amputation? But it was a matter of just trying to rally the forces a little bit. And so we started working more with the organizations and realized that it was time to bring it to the legislators. This is what we just started doing.
Oh, wow. Thank you. So, what specific laws or policy frameworks are currently shaping wound care and limb preservation in the US right now?
Well, it's a wonderful thing, Gabrielle, because we're getting action at all levels. Because, of course, it's not just the federal government, but each state has control over a lot of what they cover in the work, especially in Medicaid and people of economically challenged populations. And so we need to kind of have a multi-prong approach. So right now, Illinois did a wonderful thing and passed legislation that required insurance companies to pay for PAD screening for anyone over 65 and anyone at risk under 65 with diagnosed circulation issues, with diabetes, and etc. Insurance companies must cover the look, which means they're covering things like angiograms, echoes, things along those lines. Only state in the nation, an amazing thing that happened. Of course, I'm hoping that many of your listeners have heard and read about in the paper about the efforts to try to cap the cost of insulin at $35. It is absurd that we have this life-giving medication that is not a luxury. This is required for people to stay alive. And we so overcharge it that they're choosing between rent, they're choosing between food and buying insulin. And so we're trying to get each individual state to put a cap on. And right now we have 27 that have agreed. But it is so much better and so much easier to just make it a federal policy, just cover all 50 states. And so we do have a bill working through right now. As I said, we have 27 senators right now of the 50 that we need in order to get this legislation passed. The American Diabetes Association has filed legislation on the diabetic shoe bill. Now, your listeners may not know, but there is coverage under the Medicare and most of the other carriers that require them to cover the special custom diabetic shoes that we know save feet and limbs. We know that because they fit properly, they protect the feet, that it prevents ulcerations, which prevents amputation. And they do have coverage. The problem is that in order to get the coverage, it is so onerous, it is so layered with red tape and paperwork that more than 50% of the people that are eligible for these shoes do not get them. And that's absurd. And so APMA, working with ADA and other organizations, have been moving legislation through to make the process simpler to get the shoes in the hands of the people that really need them and deserve them. The same bill also mandates that all states cover podiatric services under Medicaid. Many of you may know that Medicaid coverage is determined by the state. The federal government simply gives them a pot of money, and it's each individual state that decides how the money is spent. There are still 4 states in the nation, and we just recently flipped Colorado, that do not cover podiatric services. And again, we have the data, we have the statistics to show that when a person at risk with diabetes, with circulation issues, sees a podiatrist regularly, amputation rates plummet by more than 50%. Finally, here in my home state of Massachusetts, I'm extremely proud that I and other folks are working on a bill that will create an amputation prevention task force within the state government. This will mean that legislators will have the power to create all the legislation needed in order to ensure that the testing is covered, that the look is covered, that everything that can be done to prevent an amputation will be available, as well as education, educating the population, educating the medical community. We're hoping that once we get it passed here in Massachusetts, and it's looking pretty good, it will then be a template for the rest of the states. And once again, we will start going state to state to get as many as we can to accept this legislation, and then go to the federal government and say, look, we got 20 states that have done this. Why can't we just make this a countrywide policy and let's get this through? So there's a lot of things going on, Gabrielle, that really good people are seeing will help do what we want to do, which is save these limbs.
Okay, wow, Dr. Alper. Oh, so where do you see the biggest gaps between clinical need and what current healthcare legislation actually supports?
Well, there's 2 things. First of all, there's the ability to get the coverage for the exams, for the testing that is needed for early intervention. We know, Gabrielle, that every 4 minutes there is an amputation in this country. We also know that 50% of these people will die within 5 years from
Mhm.
following an amputation. So this is not only saving limbs, this is saving lives. But the most important statistic that goes to your question is that we know statistically that 85% of the amputations that are performed can be prevented with early intervention and early treatment. That's ridiculous. And it's not only ridiculous from a personal standpoint, from limbs and lives, but the economics of it doesn't make sense. A typical limb amputation is $70,000 to $100,000, and that doesn't count the postoperative training, the prosthetics, everything else. That's just to amputate a limb and care for the patient. Those are healthcare dollars that are being wasted. A pair of diabetic shoes is $300. An angiogram is less than $1,000. And yet we can't get these things covered, but nobody questions the $100,000 amputation bill. And so there is your gap, that we can't get the carriers, we can't get the legislation yet that ensures that we get the early approach. And so by educating, by speaking to them, by advocating, by pounding on their desks, we're hoping to bridge that gap.
Oh, wow. Thank you. So, how does Medicare policy currently define, in quotation marks, medical necessity when it comes to advanced wound care and limb salvage procedures?
Well, that's really an excellent question. And the answer is a high risk of life to the patient. You know, we cannot get currently things like Doppler exams and angiograms on patients that are level 1 or level 2 in the world of PAD and CLI. We need to take it at a higher level. Well, of course, if they're at a higher level, they're much more at risk.
Mm-hmm.
And once a person has an ulceration, you can get more coverage. But again, when you have an ulcer, especially an ulcer that's difficult to heal, you've got a limb that's already at risk. And then, of course, there's the hurdles you have to go through to get a lot of the treatments that are available. You know, we just went through a whole change in reimbursement on skin substitutes,
Mm-hmm.
where on some of them, the amount that's being paid doesn't even cover the cost, let alone anything that'll deal with the hospital or the office costs to apply these products. And so we need to make sure that there's access. Patients need to be sick enough in order to finally get the coverage. And that just doesn't make sense. And it's not just Medicare, by the way. We certainly base things on Medicare because the other carriers often follow Medicare guidelines. But we're talking Blue Cross, we're talking Aetna, we're talking United Healthcare. All of these put up barriers and put in red tape for getting coverage.
Oh. So, how does reimbursement and policy decisions affect limb salvage?
Well, they affect it by simply saying no. You I have a patient that comes into my office and I determine that they're at risk because I see circulation changes. So I have a wound that I'm going to treat, and I can probably get coverage for the wound. I have evidence that there is a wound that needs treatment. What treatments I can give come into question, and often I have to go on the phone and get prior authorizations and get coverage when it's rejected. And of course, that all takes time. But then I refer the patient over to an interventionalist or a vascular surgeon to see if they have PAD or CLI behind this thing. But it's very difficult to get an angiogram, which is the true determining factor. I mean, yes, I can get an ABI exam covered. I can maybe get a Doppler covered, but we really need to see the patency of these blood vessels. And that's where an angiogram comes into play. And that can be very difficult. And it requires the physician to take time in their office to get on the phone and deal with these people. And often, at least the initial approach, you're not even dealing with another physician.
Mm-hmm.
So in order to get the coverage, you got to educate the person on the other end of the phone. And so it's 15, 20 minutes. And physicians just don't have 15, 20 minutes in their time of day in order to spend doing this, especially when you have multiple patients.
Mm-hmm. Yeah, you're totally right, Dr. Alper, especially like CLI and diabetes, like infection, they don't wait. They don't have time to say, "Oh, I'm going to progress once the referral is done." So that's very interesting.
Well,
What?
that's exactly right. That's exactly
Yeah.
right.
So, what battles are happening behind the scenes that most clinicians never see?
Well, I mentioned the legislation that we
Hmm.
talked, and the battle is to get more than just David Alper there. We desperately need many people doing this. And this isn't unique to our legislation. This is the way that the American legislation process works. That you need to go to the legislators, you need to go to your congressmen, you need to go to your senators. And by the way, at the state level as well, too. And you need to let them know that you exist, and you need to take the time to educate them. And what happens very often, Gabrielle, is that when I and others walk into these offices, you often don't meet with the legislator. Who you do meet with is their healthcare aide.
Oh.
And the healthcare aide is the one that has the background to understand what you're talking about and also put things in front of the nose of the legislator to say, listen, Senator, listen, Congressman, we need to look at this, or you need to consider supporting it. Now, obviously, at the end of the day, it's up to the legislator, but they certainly listen to their aides. But we need to get in their face.
Hmm.
So it means visits. Now, not everybody can just drop everything and fly to DC rather, but you can do it at a local level. You can write letters, you can make phone calls, you can send emails, you can attend things in your home state. Whether it's a fundraiser or visiting their office. Every congressman and senator has offices in the state that they represent, and you can visit with them there. And all of this is going on behind the scenes. The ADA is supporting it, American Heart Association, the Society for Cardiovascular Angiopathy, the Society of Vascular Surgeons. All of these organizations and more are doing what they can to educate these people and to beg these people to please support our legislation. But patients need to get involved as well, too. I love the phrase that patients need to own their disease. And so while we can certainly do what we can from a physician standpoint, the most powerful testimony that can be given is individual stories, anecdotal stories. So when I go to visit a legislator, I don't tell them about the 150,000 amputations every year. I talk to them about Mrs. Jones that lost her foot and can't work anymore and is helping to support her children. Or I talk about Mr. Jones that lost his leg and he used to work in a machine shop. And so what is he going to do to support his family? This is the type of stories that really make a difference. And when you have patients that this has happened to or at risk of it happening to, it is incredibly powerful to get their story in front of the legislator because that's an image that sits in their minds. So yes, me as a physician, you as a physician, other physicians can certainly give the data, can certainly give the information, but it's getting the patients involved as well too, to advocate for themselves and for their disease.
On a quick side note, how can the patients get involved in something like that? Is there a website
There
or?
actually is a website, the American Diabetes Association. It's www.diabetes.org, very simple. And then you just look under advocacy. And it's the advocacy part of the website that will guide you through this. The American Podiatric Medical Association, APMA, has the exact same thing. And we're apma.org. And again, just click on the advocacy. You
Okay.
also can go to your individual legislators. Every one of them has a website. And by clicking on that, they will show you how to communicate with them. And so you can really just take it upon yourself to send them an email through their website, which is very powerful, much more powerful than just putting your name on a list of emails rather. By creating your own that has your own specific message, that is going to get into their faces and say, wow, Mr. Smith took the time to write to me. I better read what he has to say.
Okay.
So those two websites are a great place to start. You can also go to the AHA website, www.heart.org rather, and they also have an advocacy tab that you can use to get to it.
Okay. Thank you so much, Dr. Alper. So, Dr. Alper, are there any particular procedures, technologies, or treatments that you've noticed are clinically effective but are consistently denied or under reimbursed by insurers?
Well, the first thing right off the bat is hyperbaric oxygen. We know that using hyperbaric oxygen is very effective in having stubborn wounds heal. It is currently not covered by Medicare. There are some that cover it, but not all. But here's another one. We now have the technology for incredibly early intervention. These detecting pads, these heat pads that people can step on that read the circulation and read areas that are at risk, because before the tissue breaks down, these areas get warm. Nothing you can see and nothing you can feel with your fingers. But by stepping on these pads, they look like a scale.
Mm-hmm.
It not only can read this, but it Bluetooths the information to the physician. This technology has existed for several years. It is not covered by Medicare. It is not covered by both carriers. Interestingly, it is covered by the VA. And so
Okay.
the VA recognizes that by using these pads, they are detecting when skin is going to break down before it breaks down, saving ulcerations, saving limbs, saving lives, and saving hundreds of thousands of healthcare dollars. So there are several things that are out there today that are battles to get coverage.
Mm-hmm. Yeah, like photometrics. So, Dr. Alper, do you see any financial incentives in the system that unintentionally favors amputation over prolonged limb salvage attempts?
Well, it's an interesting question. The truth is, number one, nobody's going to really admit this. Because of the fact that so many people pass away because of amputations and the likes, it actually can be cheaper for an insurance company. Covering somebody with diabetes for 40, 50 years can be expensive. If the patient passes away, and I'm certainly not saying that anybody's hoping somebody passes away,
Mm-hmm.
but bean counters, the statisticians can prove that sometimes it's cheaper to not treat. And I don't know how you really fight this, because now you're talking heartstrings rather than economics. And it does come down to economics sometimes. So yes, I can sit here and say to you, it is cheaper to open up a blood vessel than it is to amputate.
Mm-hmm.
But if we save the person's life, it can be more expensive down the road.
Yeah. But I guess, I mean, like you said, but that makes sense. Thank you for being honest and candid with that aspect of it, Dr. Alper. So, how are, in quotation marks, preventable amputations currently defined, if it is defined in a policy standpoint?
Well, it's not written anywhere per se, Gabrielle. It's
Hmm.
really just a matter of what level the wound is. I mean, if I have a patient come in with a black toe, well, gangrene is set in. Something's going to have to be removed.
Hmm.
If we have a foot that there are no pulses, it is dusky, it is cold, we, even if gangrene hasn't necessarily set in, we can tell that the time to revascularize may have passed. And so there is the Rutherford scale that works with different levels of ulcerations, and certainly level 4 out of 4 can be a time when things are at risk. You also obviously have the patient that is just not responding to care. But the question needs to be asked, what level of care? So if I can't get oxygen on a difficult wound, I may be able to save that limb, but I don't know because I can't give the care. And if I can't get the ulceration to heal and the insurance company is giving me a difficult time putting a skin substitute on it, I don't know if I'm going to be able to get that wound to heal. If I can't do an angiogram, I don't know what blood vessels are clogged. And so we don't know if we can open up these blood vessels or which blood vessels to open. So that's the challenge that we run into sometimes. So there's no green light that suddenly goes on and says, oh, this patient needs an amputation. It's the presentation that they have. But if the presentation allows us to break out the heroics, to break out the techniques and the treatments that we have, that markedly decreases the need for amputation.
Mm-hmm. So, Dr. Alper, in your view, what percentage of major lower extremity amputations could realistically be prevented if we had better policy alignment?
Well, as I said, the American Diabetes Association has hard statistics to show that 85% of amputations are preventable with early detection and early intervention.
Mm-hmm.
So if we pick up that a patient is at the very beginning stages of PAD or CLI or CLTI, that type of intervention for the circulation will prevent an ulceration. So we won't even get to the risk of an amputation because the skin is intact, the wound is intact, the limb is intact. So truly, 8 out of 10 people at risk for amputation can avoid that amputation if we can just use the techniques and technology that we have today.
Mm-hmm. Where do you feel clinicians have the greatest disconnect between evidence-based limb salvage care and what insurance or legislation allows them to do?
Well, that's a really interesting question. So I'm going to broaden the question a little bit. The first challenge we have with physicians is educating them because unfortunately, many PCPs, primary physicians, are ignorant of what is available today. They have a patient come into their office with a black toe. They send them to the orthopedist. Orthopedists do what orthopedists do, and they cut the toe off. Boom, period. No intervention, nothing done. Why does a PCP do this? Because they're unaware of what's available nowadays to revascularize a foot and a leg and toes. Many of them have no idea what interventionalists even do. And for that matter, and Gabrielle, you know this as well too, many of them don't know what podiatrists do. They
Mm-hmm.
think that we're out there to cut toenails.
Mm-hmm.
And so we're not even on the radar of referring us.
Mm-hmm.
And so it starts with educating the medical community and, by the way, the community at large, so that patients know what's
Mm-hmm.
available to them and who they should be going to. And that's on us. That's on the American Podiatry Medical Association. That's on American Diabetes. That's on the Society for Vascular Surgeons and Interventional Radiology to let the public know and let their colleagues know that, hey, I can do something about this. I can intervene on this. We don't need to amputate this foot. We don't need to amputate this leg. So that's really the level that it starts, Gabrielle.
Mhm. Well, thank you, Dr. Alper. So, Dr. Alper, if you can design one legislative change tomorrow that would most improve limb salvage outcomes, what would it be?
Allowing early testing,
Just,
allowing angiograms for anybody who is diagnosed with PAD or CLTI or has an active wound.
mhm,
If, ABIs are just not enough.
mhm,
There's too many false positives, there's too many false negatives by simply using ankle brachial indexes. I mean, it's better than nothing. It certainly should be done. It's easy, it's cheap, but it's not enough.
mhm,
And I would say if we can get the legislation for that, and if we can get things cleaned up, with the detecting pads that are made by Podometrics and other
Mm-hmm.
companies, and if we can get the shoe coverage, which we know prevents the wounds, those three things will save thousands and thousands of limbs.
Mm-hmm. Thank you. Dr. Alper, what role should multidisciplinary wound care teams play in shaping the future of healthcare policy?
Well, for starters, communication. Create these. More and more, we are seeing this. In fact, nowadays, you see multidisciplinary medical offices where
Mm-hmm.
you have a vascular surgeon, a podiatrist, et cetera, under the same roof. So I see the wound and then I send them down the hall to my colleague who's in the same office to talk about revascularization. We certainly need to encourage that more and more. There's no cost to doing that. It's just simply a matter of having marriages occur. So that's the first thing. Again, education, letting the PCPs know who to refer to and make sure
Mm-hmm.
those referrals happen. And then educating the vascular people about podiatry, educating the podiatrists about interventionalists. How many podiatrists know that they should have an interventionalist in their speed dial
Mm-hmm.
for their patients? I would maintain it is malpractice to be treating somebody with a vascular ulcer, with a diabetic ulcer, and not refer them for a vascular exam, not having a vascular surgeon to send them to, who may come back and say the circulation is fine. But the point of the story is you need to be able to get these patients looked at. So again, Gabrielle, I think the biggest tool for making the relationships that you talk about is educating, making them aware that this is what they should be doing. This should be part of their treatment plan.
I agree, Dr. Alper. You could touch a little bit on this because we said how patients can get involved, but how can clinicians, podiatry, wound care professionals become more involved in legislative advocacy?
Well, there's a couple of ways. Number one, as I talked about earlier, they themselves can reach out to their legislators. But every medical association out there has an advocacy committee, every single one of them. I know that because I sit on a couple of them.
Yeah.
By joining them, or at a minimum by saying, what are we doing? How can I help? A perfect example is with APMA's diabetic shoe bill that we now have in Congress trying to work our way through. Well, there are 435 congressmen and there are 100 senators. APMA can't reach them all individually. We just don't have the staffing. But if you, as a podiatrist that live in Cupcake, Indiana, and reach out to your congressman and say, my medical association has submitted this bill. I'm asking you, congressman, to support it, to sponsor it, to sign on with it. That is tremendous help. That is basically boots on the ground. And the more and more that individual physicians get involved with the advocacy committee of their medical communities, of their medical associations, the stronger we are and the louder voice we have. So I would maintain that every physician should join their professional association's advocacy committee.
Thank you, Dr. Alper. Those were the final interview questions, and now we're going to go into the rapid fire questions. Every- Everybody says that.
Be nice to me.
Okay. No, in your opinion, what do you think is the earliest warning sign that should never be ignored?
Redness.
Yeah.
Redness on the foot shows that there is excessive pressure. It's
Mhm.
rubbing. It is being irritated. And especially if you have someone with diabetic or other neuropathies and they don't feel it, it rubs and rubs even more. Redness also just can show changes in circulation. So we're supposed to be uniform colors throughout our bodies.
Mhm.
If you see a change in color, you should react. Now, that's not a simple rapid fire answer because people of color often are not able to detect the redness as much.
Mhm.
And so there also is the matter of swelling. If you notice an area is puffing out a little bit, that is also a sign of too much pressure, too much friction, too much irritation.
Mhm. Thank you, Dr. Alper. What's one thing you, in your opinion, believe that every primary care provider should do at every diabetic visit?
Take off their socks.
I agree. Yeah.
Unfortunately, people go to visit their PCP or their endocrinologist for their annual or semi-annual or whatever exam for their diabetes, and they make them take off their clothes and put those silly little gowns on, but they have them leave their shoes and socks on, and they don't look at their feet.
Hmm.
The best thing that they can do is to take their socks off. And I would tell you that patients should say, Dr. Jones, while I'm here, would you look at my feet?
Hmm. I do have a little side note on that, right? Because, in a lot of healthcare organizations, they give you such limited time to be with the patient. And if there could be like a policy that mandates it, for them to actually do an evaluation that, foot is like whatever, clear, no signs of infection. Because people, I mean, we've all been there. You have 15 minutes for an established patient, 15 minutes, you know? And
Oh, true.
no, yeah. So I was like, but yeah, that's what Dr. Armstrong was saying too. Taking off your socks. Just take off your
Well,
socks.
so here's the deal.
Hmm.
Right now, there is no coverage for an annual diabetic foot exam. You are correct. You don't get paid to come in just to have your feet checked.
Hmm.
It's ridiculous. Here's an analogy. Everybody knows that if you have diabetes, you automatically get an annual eye exam. Why does that happen? Because early detection of diabetic retinopathy prevents diabetic retinopathy. And we have saved countless of people's sight because of the fact of an annual diabetic eye exam. I would maintain the analogy is the same with feet. If we paid simply for an annual diabetic foot exam, which is less than $100, we could detect these things early. So that's the type of legislation that we need.
Thank you, Dr. Alper. Dr. Alper, we have like 3, 4 more. What specialty do you believe is most underutilized in limb salvage?
Probably interventionalism.
Mhm.
Interventionalists still are, number one, they're small. There are less than 5,000 in the country, so there aren't a whole lot of them out there. And there's a lot of medical deserts that don't have them. But I think the ignorance of what an interventionalist does keeps people from referring to them. And they truly are the ones. I mean, yes, vascular surgeons can open blood vessels too, but this is all interventionalists do.
Mhm.
And so making them more available, creating more in the medical schools and in the residencies, but also making people aware more that they're out there. I would maintain again that every podiatrist should have an interventionalist in their Rolodex.
Thank you, Dr. Alper. And what's one clinical pearl every resident should remember for life?
React. Don't just say, I'm going to watch it. We
Oh.
need to get these things early. So if the patient doesn't say anything, maybe they have neuropathy, maybe they're too busy and they don't notice it or whatever. If something just doesn't look right, at a minimum, look a little deeper with an exam. Don't just say, well, let's see what it looks like in 3 months, because I will tell you, in 3 months, you're going to have a black toe. And
Mm.
I've seen it even in my practice where somebody comes in with a little, and you have too. They come in
Mhm.
with a little corn and
Mhm.
you trim the corn and the skin is intact underneath and you don't treat their shoes and you don't check the circulation and they come back in 2 months with a black toe. So the best thing I could tell residents is react when something doesn't look right.
Thank you, Dr. Alper. So, Dr. Alper, thank you so much for sharing not only your knowledge, but also your decades of leadership and unwavering commitment to preventing unnecessary diabetic amputations and just amputations for the lower extremity altogether. And thank you for advocating for our patients as well as for the physicians. And I'm Dr. G, and this has been Diabetic Foot Files. Take care of your feet because they take care of you.